Ora si
like
registrerà la
Switzerland,
conferenza.
perfectly in time. And so it's an honor for me to have for SIAGASCOT for Italy, to having this webinar as a special guest, the president of ESCA, Jacques Menetrey. And so I want to say hello and welcome to Jacques. As you know, Jacques Menetrey is a professor of orthopedic surgery and sports medicine at the University Hospital of Geneva, and is a director of the Clinique La Colline in Geneva. We have also two important discussants in this webinar, in this 30 minutes with two very important Italian surgeons, Professor Pietro Randelli, which is a full professor in orthopedic and traumatology, University of Milan. He chairs the first orthopedic clinic department of the Gaetano Pini Hospital in Milan. He is a past president of SIAGASCOT and chairman of the scientific activity of SIAGASCOT. And finally, Gianluigi Canata, one of the most expert in knee surgery and ligament surgery in Italy. He is a president chairman of ESMA, and he chairs the International Society Relationship of SIAGASCOT. So, Jacques, it's on you. Welcome in Italy. Welcome in SIAGASCOT webinars. You will talk about the modern approach of the treatment of ACL associated to meniscal injury. So it's an honor for us to have you here.
Grazie mille Massimo, grazie a SIAGASCOT per l'invito. Thank you very much for having me today. Obviously, in 15 minutes plus, I will not cover all meniscal injury. I will focus mostly, I would say, on the modern aspect and more on the dynamic aspect. You are all aware of the Save the Meniscus logo, and we belong all to this new society. But tonight we will maybe talk about more saving the meniscal function. Those are my disclosure. Well, for the youngest in the audience, a little reminder, the meniscus, since we are going to talk about the meniscus and not very much about the ACL, that you all know the technique and the outcome. A reminder, the meniscus is a mobile fibrocartilage, is a mechanical stress spreader. The medial meniscus is less mobile than the lateral. We used to say the medial meniscus is the meniscus of the stability, and the lateral is the meniscus of the mobility. Well, the major contribution of the meniscus, it's a load distributor, it's a shock absorber, and it's a stabilizer. And this is on this aspect that we will discuss tonight. You know that the meniscus has really a very fusional relationship with the cartilage, and probably the better way to illustrate this thought is to look at the picture of the lab of Henning Madry, where you can see that actually the cartilage is relatively thin where the meniscus is present, because probably the meniscus is really taking the load in this part of the joint. But also, and this is very old work, but this is a work that is extremely worth seeing again. The meniscus, either on the medial or the lateral sides, is relatively well vascularized at the periphery, where the lesion that we will speak about are located. Don't forget, the meniscus is a dynamic system. Your menisci are moving from extension to flexion. They are moving when you are doing rotation. This is really a system that allows the joint congruency to be achieved in any joint position. Well, as I told you, I will not discuss tonight about longitudinal tear of the meniscus or radial tear of the meniscus. I will rather focus on more peripheral lesion. We will discuss briefly about meniscosynovial lesion. We will discuss about lateral posterior root tear insufficiency, about lateral meniscus instability. We'll talk about a little bit about the relationship between the meniscus and the hiatus popliteus. Well, why do we do so? Well, in our experience and based on the mechanical work that has been published over the last years, we do see this system of rotational stability within the joint as a shape of 8. or H shape. You can see that on the medial side, you have the posterior medial belt that will sustain, and with, I will say, the help of the capsuloligamentus system, that will really neutralize all the rotation in posterior medial and anterior medial rotation. On the lateral side, this is even more obvious with the menisco-ligamentous structures. You have the posterior belt that will link the PCL to the lateral meniscus, and you have the anterior belt that will link the popliteofibular ligament and the lateral meniscus towards the ACL, obviously working in combination with the capsuloligamentus system in these both compartments. And this is why this is so interesting to link the meniscal function and the meniscal anatomy to this system. Those systems are dynamized by the semimembranosus on the medial side and by the short head of the biceps on the lateral side and the capillary fibers. Well, now if we come back to the ACL associated injury, you can see that if you look at the literatures, the meniscal injury concomitant to ACL have been found up to 60%. Very recently, we conducted a study on 314 consecutive ACL patients, and we applied this systematic arthroscopic evaluation following this figure of 8 in order to look at all the different structure of the meniscus and testing the different structure as well for the, I would say, stability. What we found is that actually isolated ACL tear are relatively rare and sparse. You can see that only 1/5 of these cases were not associated to meniscal injury. If we look further in details, you can see that 40% of these injuries were concerning the medial meniscus, about 20% both menisci, and about more than 55% the lateral meniscus. On the medial side, we got a couple of root tear. We got a good amount of ramp meniscosynovial injury, some bucket handle tear, and some longitudinal one. On the lateral side, root tear were not that infrequent. Complex or posterior horn instability was also frequently encountered, as well as all the posterior lateral that we can see and find on this aspect of the knee. Well, I'm going back to the ramp lesion for a few words. You know very well the ramp lesion. I will not go too much into details. Obviously, the recommendation is just to systematically go in the posterior medial compartment to check out the presence or the absence of this meniscosynovial injury. We do routinely use the trans-notch approach to really perfectly look. If it's not sufficient, we do a posterior medial portal in order to really evaluate precisely how the meniscus is fixed behind it. The anterior view is very important, but very often the meniscus looks good from the anterior view, and you must pass behind to see it well. What I'm going to speak a little bit about tonight is this all-inside fixation of the ramp lesion that we do now for more than 2 years. Obviously, this is not applied and implemented in all type of ramp lesion, but the type 2 to 5, according to the Tanner classification, are suitable for this type of fixation. Obviously, you have to find a medial meniscus instability, and you have obviously to look very well in the posterior medial aspect. You have here one example of a 24-year-old triathlete, ACL plus meniscosynovial lesion. Well, from the, I would say, the anterior view, there is not much to say about this medial meniscus, but when you glide through the notch towards the posterior medial, you find clearly here a meniscosynovial lesion and a ramp lesion. Well, in this type of case, we place either inferior or superior sutures. Here, a little trick, you really have to reduce your meniscus before you will launch your pellets of this all-inside system behind the meniscus to make sure that your pellets will be behind the capsule. Obviously, if you do not reduce the meniscus properly, your pellets will be in between, in the gap of the tear, and that will not be good for sure. Then you will see how the meniscus can be reduced by the tensioning of these sutures, And finally, you will reduce it completely by pushing with the suture cutter, and you will get a proper reduction and fixation of your meniscus. Does it work? Yes, it does. That has been, I would say, shown now in the lab that it's a safe and effective technique to fix those posterior medial meniscal ramp lesion. How about posterior root? Once again, the Laprade group has came up with a very nice classification of those posterior root tear. Peterson in Germany has described very nicely the partial posterior root tear of the lateral meniscus. And this is what we'll be interested in. For, I would say, the classical root tear, we do use the pull-out repair, as probably most of you are using with transosseous sutures that we put in the posterior horn of the lateral meniscus. For the partial tear, once again, this is extremely important to meticulously look at the aspect of the root. And usually when we have a type B or 2, this is indication to try not to do a transosseous one, but to do, for example, an all-inside technique. And you can see here one example in these football players with ACL plus lateral meniscus with this insufficiency or partial tear of the posterior root. Classically, what you find is an instability of this posterior root or posterior horn, sorry, of the lateral meniscus. And you can see that there is some insufficiency. This is difficult to find the tear in this type of cases. Well, we usually refix, I may say, the lateral posterior horn by using either horizontal or X-shaped sutures, as you can see illustrated here. Once again, this is extremely important to place correctly your pellets behind the capsule, and then you can retension properly the posterior horn of your lateral meniscus. So according to the type of tear, you may use one horizontal, two horizontal sutures, or one X-shaped sutures. You can see that you are able to retension and restabilize this posterior horn of this lateral meniscus. Well, does it work? Once again, based on the mechanical work and that has been tried, it really add, I would say, and restore a better stabilization of your, once again, rotation in the lateral compartment. Another injury I would like to share with you is this isolated posterolateral corner injury that really, I would say, is located on the hiatus popliteus. Usually you find it by a hypermobility of the lateral meniscus. You have a posterolateral rotatory instability. You have a lateral drive-through test positive, and you have sometimes this so-called crescent sign that you can see on the right-hand side. Well, how does it comes? Well, you have usually a hypermobility and instability of this lateral meniscus at the level or at the location of the anterior hiatus popliteus. When you go into the hiatus, you can find this lateral drive-through test positive, where you can see the tibial plateau. You can even see there the popliteofibular ligament starting on the right-hand side. So what do we do in those type of patients? We usually refix the lateral meniscus by vertical sutures, superior or inferior to the meniscus. And then we will obviously recheck the stability of this aspect. By doing so, actually, we reconstruct somewhere the anterior aspect of the hiatus popliteus, and we neutralize the rotatory instability, once again, the posterolateral rotatory instability that can be classified as subtle. Of course, this is not a huge one. Does it work? Once again, we do know that if you stabilize, once again, and neutralize those rotational instability, you will put your ACL graft in a better mechanical environment, and it will favor the functional result and sustainability of the result. Well, in summary, I will really encourage you to meticulously look at all these different injury by making a meticulous examination either clinically first and then during the arthroscopy. And you will find several of these lesions, at least in our type of population, which are made of alpine skiers and football players mostly. You should always, I would say, test the meniscus, evaluate it, look at these subtle instability or injury, look at the meniscotibial ligament on the lateral side, look at the root, look at the hiatus popliteus, look at the meniscosynovial side on the medial meniscus. We know that if you take care of these injury, you will probably improve your result. That has been well, I would say, demonstrated in biomechanical studies, and that will come now on the clinical side for sure. There is many repair types, or I would say the industry is really providing many different devices to repair this meniscus. You need to have a specific angle, you need to have a specific, I would say, rigidity in your system to be able to achieve these type of fixation, but this is really feasible. Once again, it may be challenging, but try to go to the lab, try to go to any advanced course to really, I would say, practice this type of technique, because once you have it in your toolbox, this is really something that is extremely useful. On that, and before answering to all your questions, I will really invite all of you to our virtual meeting that will take place next week with 7 channels, with more than 450 experts, 130 hours of education, and the highlights, keynote, ICL, symposia, and so on. We will have a special resident days on May the 11th. And you can have access to all this program on demand for 3 months. So it's really worth, I would say, registering for this Congress and then see everything you would like to see for 3 months. You can even see it on the beach on your cell phone. I thank you very much for your attention.
Thank you so much. Thank you so much for your lecture. It's very interesting, and thank you to have remind us all to the SIAGASCOT people for the next week to go and to look at the ESCA meeting. Virtual meeting will be a really interesting experience. We can grow up with the scientific program that ESCA will offer to us. So I give the comments to Pietro and to Gigi. They are the 2 discussants, so you can open the discussion. And if there is anybody want to make any question to Jacques, you can write it, or you can use your microphone and ask your question. So, Pietro, it's on you.
Thank you, Massimo. Thank you very much for the idea to invite the president of ESCA to do to present such an interesting lecture, because really we are really looking how to fix the meniscus every day, and how much we can push the envelope in this, because for sure the contribution to the stability of the knee from the menisci is very important. And so I believe that everything that Jacques told us is really important, and we have to try every day to save as much meniscus as that we can. So from my point of view, I would start with some question. I don't know if Gigi Canata has some questions, but I will start from the technical point of view, and then we will go on with the discussion. What do you think, Gigi?
Yes, it was a really interesting presentation, and it's a new knowledge for a lot of us. And yes, I have some questions, but there are dozens of questions. To start are the age limits and the axial deformities. How do you behave in considering these 2 aspects, Jacques?
I think this is a very good question. Thank you, Gigi. This is where we still need science. This is, I would say, on the elderly menisci, if I can say so. Obviously, we know that the biology of the meniscus will decrease with ages, but as you know, for the ACL reconstruction, we now have evidence that it works very well in patients over 50 years old and over 60 years old even, depending obviously upon the personality of the patient. Now, for, I would say, more than 2 years now, we have started to suture also those whole meniscus. And we are now in the process to evaluate our results. But I may say this is still based on the observation of the outcome of these patients. The results are very promising. Now, when we talk about peripheral lesion, and those peripheral lesions can also occur in, I would say, patients over 50 years old, because they are still skiing, they are still making rotational activity. That could be tennis, that could be hiking, that could be gliding sports or water sports. I will really, and we do it as the same treatment as we do in the youngest for this peripheral lesion. Because once again, at the periphery, maybe in older patient, we have a little bit less vascularity, but still there is a big potential for healing. And I will really keep doing it in this patient, I would say over 50. Now, with respect to the axis, obviously there we were in the situation where we were talking about ACL plus meniscal lesion. Those lesions are, as you know, mostly found in male between 15 and 30 years old, mostly found in female with one peak at 50 years old and another peak at 40 years old. So that's clear that here we have a population that is much younger than the one we have for axial correction and let's say degenerative changes that may be the reason or the rationale to change the axis. We keep, I would say, the cutoff value of plus minus 5 degrees to consider if we have degenerative changes. I'm talking here about the old football player, 37 years old, medial meniscectomy, let's say early in his career, is coming to your clinic after his career with a painful, unstable knee, with a varus of, let's say, 10 degrees. Of course, you will do an osteotomy in this case and fix maybe the ACL according to the instability.
And Jacques, regarding the hyperlaxity of the patient, is hyperlaxity of the patient a contraindication to meniscal suture? And what are the other contraindications that you see in your practice every day?
Well, this is another very good question. You know, in our first group of posterior lateral instability plus meniscal hypermobility, we had about 30% of hyperlax patient. Therefore, this is definitely a risk factor, at least for the lateral meniscus, to have that kind of meniscocapsular or meniscosynovial injury for sure. It does not, I would say, contraindicate the meniscal repair in these type of patients. Now, as you know from the ACL surgery, this is patient that we have to particularly taken care in the post-op period in order to protect a little bit the last degree of extension in the first week after the operation. Obviously, if you repair the meniscus, you will put those patients on crutches, so you will let them a little bit, I would say, more quiet than a regular isolated ACL. Therefore, that will favor also the healing of the ACL graft.
And the other contraindication that you have to repair the meniscus is maybe the lack of time in between the injury and the surgery, chronic lesion. What are the other contraindications you have?
Well, to be honest, Pietro, I think we try always to repair it, even though, I mean, we take the risk of a failure, as we say. And I think in this approach of these meniscal lesion, you have to take the risk of a failure, because there is no good evidence, especially coming from Versailles and the Philippe Beaufils group, that showed that if you suture a meniscus and it failed, you will remove less tissue, less stock of tissue when you will revise your failed sutures rather than the first meniscectomy per se. Therefore, we always try to fix the meniscus. In some cases, we do a so-called salvage procedures where we sort of make a package of the meniscus at the periphery to try to save as much, I would say, meniscal stock as possible, or meniscal volume.
Thank you so much. Regarding the technical point of view, two aspects I'd like to have clarified by you. The first one is that on the medial side, when we have a stiff knee, then we can do a needling of the MCL, getting some space, more room, and doing a perfect repair. On the lateral side, when you have a tight lateral side, do you have any specific trick to perform the meniscal suture?
Yeah, good point. On the medial side, you mentioned it, we never, I will say, stop to do a pie crusting. I think pie crusting is a good technique to open up safely your medial compartment, and we do it. On the lateral side, it's much more difficult. The thing I didn't say, I didn't have time to say it, but initially, those meniscal injury, the instability one, we were treating them openly, because actually the one who taught us how to treat those one is Werner Müller. And Werner Müller was doing his Werner Müller plasty in an open way. And therefore, initially we were treating those menisci open, by an open approach. If the lateral compartment is too tight to get properly your sutures properly placed, I will recommend to do a small open incision and fix it from, I would say, the deepest layer to the most superficial one, making an arthrotomy right in front of the popliteus tendon to perfectly expose the anterior aspect of your hiatus popliteus, and from there you can start doing it well. For the root tear, this is, I would say, the only way, well, this is the only lesion that you can fix, at least with all inside, even though you have a tight lateral compartment.
Okay, that's perfect. And from the point of view of the relationship with the popliteus tendon, I usually fix the lateral meniscus when I have to suture and this is unstable to the popliteus as well, as the French they did since a long time. Do you fix it to the popliteus, or you try to avoid to include the popliteus in your suture?
No, I think that if you have, once again, if you have an unstable meniscus and you have this really lateral drive-through test positive, you have to fix, you have to put one sutures in between the meniscus and the popliteus tendon, because you have to replicate the fascicle, the popliteomeniscal fascicle that are coming at the anterior aspect and posterior aspect of the hiatus, and to replicate the anterior popliteomeniscal fascicle, you need to put the sutures into the popliteus tendon. Therefore, I always place one suture in the popliteus tendon, and usually I place one or two more sutures at the anterior aspect of the hiatus popliteus, according obviously to the extent of the lesion.
Thank you very much. And Gigi, do you have any question regarding the technical point of view, or we can switch to the post-op treatment?
There is a question from the audience. The question is what to do in partial lateral root lesions.
So once again, there is, I'll say, we follow this algorithm. If the lateral posterior horn or medial posterior horn is unstable and the injury takes less than 50% of the thickness of the root, we fix it now with all inside technique. If the tear is more extensive than that, then we use the classical pull-out repair with transosseous refixation of the root. But once again, the root of the meniscal is crucial because this is from the root that starts the hoop stress effect. And if you do not fix the root properly, you will lose your hoop stress effect, and therefore you will lose the function of the meniscus. This is why I entitled this presentation, Save the Meniscal Function, because somewhere this is a way to save the meniscal function. Therefore, we will always address it. Partial root tear, we always address it today.
Thank you, Jacques. And regarding the post-op treatment.
Sorry, I have two questions for Jacques about the ramp. If it's possible, how to treat the ramp. The first one is you always use an all-inside technique and never a posterior medial approach. This is the first. And the second one is when you find a ramp with a scar tissue stable, do you repair it in any case or not?
So to respond to your first question, Massimo, after I had a big discussion with Andrew Amis, I started to do all my ramp lesion all inside for a very simple reason. At 90 degrees of flexion, your ramp is not reduced. Close to extension, as we are in the arthroscopic position, your ramp lesion is perfectly reduced. Therefore, now, obviously, well, say for more than 2 years, we have fixed as well, maybe we did one through the posterior medial approach. All the others, we have treated them with all inside technique. The second point, once again, I really evaluate very well the stability of the meniscus, especially I looked if the medial meniscus is floating. It means that the meniscotibial ligament has been either elongated or insufficient. In this case, I will place maybe 1 or 2 sutures inferior to the meniscus, in the meniscus and into the capsule, sort of a vertical sutures to make sure that is properly fixed.
Thank you.
Thank you. Regarding the post-op regimen, do you limit flexion to 90 degrees? How long you keep the crutches and partial weight bearing or no weight bearing? What is your rationale?
So if the hoop stress effect has been, I would say, concerned by the lesion, so root tear, radial tear, partial root tear, we let our patient 4 to 6 weeks non-weight bearing, and we limit the knee flexion at 90 degrees of flexion. If this is a meniscal synovial lesion at the periphery that is partial, such as the short ramp or the posterolateral corner, in this case, we will load 20 kilos of weight bearing, 90 degrees of flexion for 4 to 6 weeks, according to the extent of the lesion. And we allow the full load when the leg is in extension, in complete extension.
Okay, that's perfect. And do you use brace or not in these people together with the ACL reconstruction?
We use brace that are purely protective. That means the patient is wearing the brace only when he will go outside. I don't know in Italy, but in Geneva, the sidewalk are extremely dangerous nowadays with all type of vehicle that are on the sidewalks. Therefore, for the patients, it's maybe safer to have just a protective brace when they go outside. This is the only brace we use.
And when you speak with the patient regarding the possibility to have a re-tear of the meniscus, what percentage you tell them? For instance, I say you have around 16% of risk of having a new operation for the meniscus. That is not my experience, because much less, but the literature says around 16%. What do you tell them?
Well, this is once again, for me, a meniscal tear or a meniscal instability is one indication for ACL reconstruction. And we know that if you reconstruct your ACL in the same time you will suture your meniscus, you can increase the success rate to I would say, above 80%. So this is the first comment I make to my patient. Then the second comment for all, I would say, the peripheral lesion. This is on the way to be published, but we have really a good rate of success that is above 95%. And we very rarely have to revise or reoperate those patients. Therefore, I just try to give them those figures that are coming from our own data. And then I let them always the choice. We never decide about the strategy of the operation right at the first consultation. I tell them, think of it. I have explained to you many things in a short period of time. You think of it and you come back to us and you say, okay, I want it or I don't want it.
Luigi, do you have any question?
I think
We have 145 people connected, Jacques.
Yes.
So, you know,
great.
it's a great. Thank you, really.
Thank you all. Thank you all. It's a pleasure. Thank you very much. Grazie mille.
Jacques, I have a question about the return to play. In your experience, do you use a different return to play when you perform an ACL isolated or an ACL plus ramp suture or a root suture?
Yes, Massimo. As you know, we will do nowadays, we will do a battery of return to play tests to validate or not the recovery of the patient. If we have an isolated ACL, we usually do those so-called functional testing between, I will say, 4.5 months to 6 months. If we have I would say, a concomitant meniscal repair, we will defer and delay this functional testing by 1 or 2 months. That means maybe around 6 to 8 months. And obviously that will delay a little bit the return to play.
And
especially in,
sorry.
Yeah, I would say especially in pivoting sports, right? Such as football, such as basketball, such as alpine skiing, etc.
What do you think about the information that gives you the MRI?
Another very good question. For the peripheral lesion, MRI is very bad. And I don't know the quality of your radiologist in your different cities, but at least here we have always a big battle with our radiologists because they do the MRI very fast with a few sequences and they very often miss those lesions. For example, for the hiatus popliteus, if you want to really investigate by MRI this dislocation, you need to place your antenna in a very special axis, and they never do it in the institute that we have here. Therefore, I would say MRI is not a very great help for this type of injury, and they are, I would say, very sparsely conclusive.
Thank you. Another question from Gigio and another question for Pietro, if you have a question, or from the audience.
I have a question, Jacques. In the case of effusions, sometimes we can see them. How do you behave? Do you stop rehabilitation? Do you use other solutions? What do you suggest?
You mean post-op, Gigi, or pre-op?
Post-op. Well, in the rehabilitation time.
I usually tolerate an effusion up to 6 weeks or 30 days, but no more than that. If there is effusion that remains at 6 weeks, I need to understand why. And usually what we do is that either we restart anti-inflammatory medicine, but very often we just take it easy and slow down about the rehab to let the patient recover in the week or 10 days that follows the consultation. Effusion should not happen, I would say, after, once again, 6 weeks. Otherwise, something is wrong. That could be a chondrolysis, that could be a big inflammatory response, that could be a failure, an early failure of anything, repair or whatever. So if we cannot address, I would say, the effusion or the swelling by a simple mean, we will investigate it. Either, obviously, we will drain it if it's a big one, but we will very often redo an MRI, for example, to make sure that anything is wrong and nothing is wrong. And we will really pay very much attention to those patients that we will very carefully and closely follow.
Okay, thank you. And another, maybe the last bad question, Jacques. You can forgive me. Sorry. Do you have any difference in the treatment of the meniscus regarding the kind of sports, and especially regarding the kind of professional? If you treat professional athletes, you change the strategy, or you try to save more menisci that you can?
Now, I try always to, I use this US study about meniscal repair and cartilage injury as well, showing to a professional athletes, and mostly it's not the athletes you should convince. This is very often the agent that you need to convince that the proper strategy will be to save the meniscus, because it will improve the performance of the athletes down the road. In all the sports where statistics are very important, you can clearly see that if you retrieve the meniscus of a knee, your athletes 2 or 3 years later will see its performance decreasing. Therefore, I try really to convince the athletes and his relatives or his agent to do so. But I don't know, Pietro, if you have a spy on board, but just today we had to cancel one surgery in a very young professional athlete who had a lateral meniscal injury, and he had it for all the last season, and his agent told him that he was not at a good way. This was not a good way for his career to have surgery now, so he have to suffer another year before getting operated upon. And the young athletes just believed in his agent, so he canceled the surgery today. So this is always a difficult discussion with professional athletes, but once again, you have to present them as objectively as possible what are the data, and they will make their choice with their surrounding people, and with, nowadays in professional sports, the agent really have a big place.
My last question is from Barcelona, not from Milan. Do you think that cells could be helpful in improved healing of your suture, of your repair of the meniscus, or not?
Massimo, can you say it again? I did not understand which mean.
Do you think that cells cells could improve the healing of your repair of your meniscus?
Sure. We don't use systematically, for example, PRP or other thing, but we systematically do a very small, I would say, activation of the synovial sheath in the compartment that is concerned by the repair. We know that if you activate stem cell from the fat pad, for example, or from the supratrochlear fat pad, you may get those cells that will migrate into the lesion and that will favor the healing. Yes, I think this is a good way to improve and enhance the biological process.
Perfect. Are there any other questions? I have a question, the final question to you, Jacques. Tell us why it's important next week to attend to the ESCA meeting.
Thank you very much, Massimo. So ESCA will provide to you 130 hours of education, where all those topics, including this one, will be covered. But I would say what is the most important for all of you is that you will be able to go do your shopping during 3 months with your registration. During 3 months, you will be able to access to all the program on demand, like if you were on Netflix or in other platform, in order to see all the symposia, the ICLs, the keynote lecture, the highlight lecture that are on the platform until mid-August. So for a very good price, you can have access to a lot of extremely good and I would say specific education.
Well, I'm very proud and honored to have Jacques Menetrey, President of ESCA, here in SIAGASCOT, and it was a great lecture in 45 minutes and not 30, so with a little bit delay, but it was important. I want to say hello, Jacques, thank you so much. I leave the final words to Pietro and Gigi. We are honored to are your friends and friends of ESCA.
Thank you, Massimo.
Thank you, Jacques. We really were honored, and your lecture is inspiring and is helping us to continue saving meniscus, and that's very important. And it's very important to be updated. And you showed us with your lecture that we are never updated. We should update us, and the ESCA meeting will be a fantastic chance for everybody to be updated. So I suggest all the young guys connected to be part of the ESCA meeting and to be enrolled in the ESCA program and to work for ESCA and to study with ESCA and to improve their skills with ESCA, because that's a fantastic group. And Jacques Menetrey is one of the greatest presidents of the society. Thank you, Jacques. Thanks a lot.
Thank you, Jacques. Your talk was an excellent example of what the attendees to the next ESCA Congress will get following the Congress. Thank you, Jacques.
Thank you, Gigi. Thank you all. Thank you very much for having me. And see you next week online.
Exactly. See you next week, and good luck for the meeting, for the ESCA meeting. Thanks again.
Thank you very much.
Bye.
Thank you, Massimo.
Thank you. Bye-bye, Jacques. Thank you.
Bye.
Grazie a tutti quelli che hanno partecipato, sono stati numerosi, e devo dire grazie alle scuole di specialità, ai fellow, a tutti quelli che si sono collegati, delegati regionali. È stato uno splendido 30 minuti con 45, anzi. Grazie ancora, buona serata a tutti.
Ciao.
Buona serata.
Ciao.
Bye bye.